It's my pleasure to introduce to you Associate Professor John Massey. John is a paediatric respiratory physician at the Royal Children's Hospital in Melbourne. He has a special interest in caring for children with cystic fibrosis and the respiratory complications of neuromuscular weakness. John is a clinical associate professor at the University of Melbourne and a research fellow at the Murdoch Children's Research Institute. His interests in cystic fibrosis include diagnosis, newborn screening, genotype, phenotype correlation, and community-based carrier screening. He's worked in collaboration with the Victorian Clinical Genetics Service to establish a cystic fibrosis carrier screening program in Victoria in 2006, a program that has actually now screened over 15,000 people. He is part of the Genetic Society of Australasia Committee that developed the Genetic Society of Australasia policy on carrier screening for CF. He has collaborated with the Centre for Health Economic Research and Evaluation in Sydney and published a number of studies on the health economic aspects of carrier screening for cystic fibrosis. Please welcome Associate Professor John Massey.
Thanks, Karen. Thanks, everybody. I've got a few slides, but mostly what I want to do today is just talk to you. I don't know if anyone wants to come a bit more to the front. We've got lots and lots of data about CF and carrier screening, but I think listening and hearing the story is far more interesting. Before I go any further, I just want to let you know about conflicts of interest, and I hope during the meeting that you hear from speakers about conflicts of interest. So simply, financial conflicts of interest, I have none. No money from the drug companies. I don't see the drug reps. I'm not involved with any of the companies doing carrier screening with any of the technologies. My trip is funded by the Medical Education Fund from the hospital. Sometimes there are other things actually that can influence this that are biases that I think are worth acknowledging, and that sort of partly comes out of my work in medical ethics. And so I haven't said this at a meeting before, but I have three cousins with cystic fibrosis who lived in England. One passed away at the age of 13 in the 1970s, a sister at the age of 42, and their niece is 30 and well. I don't know them super well. And whether it's relevant or not, I come from an Anglican faith tradition, but actually when we talk screening, religiosity doesn't actually seem to play a big part for most people. I got interested in carrier screening basically out of newborn screening. So when I started in Sydney back in 1995, genetics was part of newborn screening, and I'd be involved in discussions with new families as I still am. And one of the things that struck me was that we'd be talking with the new families and we'd say, well, this is a genetic condition, and there'd be a number of sessions. So, by the end, we'd be saying, somewhat hopefully, look, now we know you're both carriers. This is to the parents. Now we know you're both carriers. In subsequent pregnancies, you can make some choices. And the parents would often look somewhat strangely or angrily at me and say, but we had testing before Jimmy was born. We had testing for Down syndrome. We asked for everything to be looked for. And now you're telling me that on newborn screening you've picked up this 508 gene mutation. They're quite available in the laboratory, but you only done it after he's born. Why didn't you do it before, or at least offer it to me before? And of course, I had nowhere to go with that very logical and sensible question, and I think we're in a really difficult position, and I actually don't think it's a very strong ethical position to be offering a test after birth when, in fact, the same technology, and it's simple and easy to apply, is available before birth. Not that necessarily everybody wants to avail themselves of it, but people need choice. Now, not few of you in the room know me. I pride myself on being nearly impossible to offend, because I don't really take things to heart, but this was attached to an article I wrote and we had published in Archives of Disease of Childhood, and had nothing to do with carrier screening, but was about a newborn screening issue. And then they made this cartoon, and it's sort of rather clever in a way, but actually really dark and sinister, that somehow I might be advocating that we all go through, like in the airport, you go through the screener, and someone there looking very military is taking notice of the results. And this is actually absolutely everything that, in my mind, screening is not about. And so you might be wondering why I'm suited up today, because again, those who know me know I'm not really a suity sort of guy, but it's this sort of Kevlar fibre that's bulletproof, and it's lined with Teflon. So if there are any misunderstandings, I'll be safe, but hopefully that today we don't have any misunderstandings. Carrier screening and carrier testing is about choice. But it's a funny thing about choice, is that if no one tells you you've got a choice, then how do you make a choice? And that's actually the situation that I think most people find themselves in Australia and probably around the world at the moment. There is a bit going on with screening in the community. You know a little bit about it. There's stuff for bowel cancer. That's a partially funded program. There's screening programs, mammograms for breast cancer, pap smears, and prostate screening, a lot of cancer phobia, not unreasonable. During pregnancy, there are 20-week ultrasounds, and if you live in Victoria, 90% of women in Victoria have some sort of screening for Down syndrome. So that to me tells me that quite a lot of people are interested in finding out about the fetus. What you probably don't know is that if you're pregnant and you have a full blood count, standard medical thing to see what your haemoglobin is, if your haemoglobin's low but you've got normal iron, it probably means you're a carrier of an illness called thalassemia. So you don't mean to have that. You have that test for your own health. You find out you've got thal. They do the gene test. They then test your partner. And in fact, it's very rare now for babies to be born with thalassemia. So people in the Southeast Asian and that's Mediterranean communities where thalassemia is very common, and in some ways not unlike CF, long-term difficult illness to manage, people make choices. And that happens. And if you're Jewish, Ashkenazi Jewish, most Ashkenazi Jewish people are screened in school. Started with an illness called Tay-Sachs, really nasty illness with developmental regression, and most babies died before about 4 or 5. But in that community, carrier frequency, 1 in 25. Quite accepted, quite common, and so this sort of screening is happening out there in some populations, or inadvertent screening. But we don't actually have screening for cystic fibrosis very commonly. This is a prompt to make sure that we're clear about definitions. So carrier screening is about doing a test to look for a CFTR gene mutation in someone with no family history of CF or being a carrier. Most people will be test negative. You don't need tons and tons of genetic counselling to take the test, although you do need good information. And I think that's where our CF organisations, all the states and CFA, really come into play, and are hoping to convince you that there really is a role for CF organisations to support carrier screening, and this is one way. It's not very well, it's often implied, but needs to be clearly stated that screening should be informed, it should be voluntary, and it should be supported. And that's different from carrier testing. So carrier testing happens when there's somebody with cystic fibrosis in your family, and the likelihood of being test positive is quite high. And so that's a whole different ballgame. But part of what we want to do today is think about those together and where the CF organisations fit. And they've been doing some work in Victoria about carrier testing and carrier screening. Currently though, of course, you know that most babies with CF are detected by newborn screening, that 2 or 3 family members will take up cascade family testing. So if you think, wow, well, we can find out who's in the CF community, we can test all their relatives, then we'll know most of the carriers in the community, and that's a way to do it. In fact, it doesn't work that way. Like any recessive disease, most people don't know they're carriers, and going through the CF community won't in fact be a way to find all the carriers. So we also know that about 2/3 of people who have a baby with cystic fibrosis, if they decide to have more kids, and sometimes they're at the end of the family or decide that's just enough, but about 2/3 of families, if they have further kids, will actually use carrier, some sort of prenatal testing or pre-implantation genetic diagnosis on subsequent pregnancies. So what do the health groups say? Well, one of the health groups has come out pretty clearly and said everyone in the early phases of pregnancy or planning a pregnancy should be offered carrier screening. And I think the wording is really neat there because it's about being provided information that it's available. You don't have to take it up, but if you're not given that information, you're nowhere. So that's from the Human Genetics Society. The College of Obstetricians has buried a comment deep in their prenatal recommendations, which says if there's an illness of high perceived risk, then you can ask for a test. I don't know, perceived risk to who? The patient? The doctor? It's really unclear, but they didn't want to come down and make any specific mention of cystic fibrosis. There are other recommendations out there. So I put the HGSA one, the positive one, but in the United Kingdom, they came out in 2006 and said we don't recommend carrier screening. And in fact, they closed down the Scottish program and moved to newborn screening. The two are not alternative, they're sort of mutual really. And they based that on a 1999 health technology report that clearly said that. So they closed it down, didn't support it, based on a statement by their own technology people, which was that. The Canadian group also said we don't support screening, and they said this is based on level 3C evidence, which is really right at the bottom of the pile of evidence. And the French also said we don't support carrier screening, and they said something like our obstetricians, if you think there's a high perceived risk, then have some screening. So it's interesting that those negative statements, I don't think are based on an awful lot. So what's going on in Australia? There's much more detailed information. If anyone's particularly interested, we've published that just at the beginning of the year in the Australian Journal of Obstetrics and Gynecology. But from 2006 in Victoria, we've been running a CF screening program. It's now moved on to include other illnesses such as spinal muscular atrophy and Fragile X, but at the start it was just CF, $220. Subsequently, HealthScope, which is one of the pathology services, has got into the market too. So they offer screening, and I think Melbourne Path do as well. In New South Wales, Hunter Genetics have a program, but it's mostly about carrier testing for relatives. But if you turn up and you're interested, you can get a 508 test. Not particularly actively promoted, so not many people in New South Wales have access. Sydney IVF for years every couple of years, they send out a fax to all the obstetricians and say, if you want to use CF carrier testing in our group, you can. They mostly do it for people with IVF and donor eggs and sperm, and similarly with Queensland Fertility. So they've screened a lot of people, but they're people who are infertile, who perhaps have absent VAS, or who are donating sperm or ova. So there's not really a very strong place of community screening in Australia, Victoria being the strongest. So in Victoria, we screened about 10,000 people up to a couple of years ago. Now, as Karen said, it's 15,000 in our last report though. Just when it was CF, found about 300 carriers, about 15 carrier couples. Mostly it was women who got screened. Most of the carriers, or most of the people were already pregnant. There were 11 affected pregnancies in that first 6 years, 11 carrier couples, and 3 affected, and they all went for termination of pregnancy. So why do we have anything going at all in Victoria and nothing really in Australia? And I think it's because there are a lot of disconnected elements of CF screening, and I'll talk about that again at the end. But in Victoria, there is a close working relationship between CF Clinic at Royal Children's Hospital, the Genetics service, VCGS, Genetic Health. Bruce Lafloy is an academic part of the Murdoch, and in particular, CF Victoria. And because we were able to pull that group together, we were able then to have a semblance of a screening program. And it was Stephen Murby particularly, who was the CEO a few years ago in CFV, who taught us, rather than being counterintuitive, rather than CF organisations being just about support and promotion of people with cystic fibrosis, it's also about community awareness, and in fact that everybody who gets screened now knows about cystic fibrosis, and join that network of people who know something about cystic fibrosis. So I think that the CF organisations really have a role in promoting carrier screening and carrier testing people there. And this was some of our original screening packs. It would be done off a cheek swab and mailed in, although currently the testing is by blood. But technically it's not very hard to do. So in Victoria, I'm going to stand now. Does anyone have any questions? It's a small group. We should pop up and ask. Yes?
Just want to go back to your comment about thalassemia carriers.
Yep.
Why are GPs and obstetricians not, why are they not more educated about the fact that a thalassemia carrier could potentially be a CF carrier? Because the fact that I'm a thalassemia carrier is because when I was 18 years old, when I was quite young, so why was it back then that the multiple GPs and the obstetrician I've been to never once mentioned that possibly I might be a CF carrier, because that could have potentially avoided having a child with CF, because my husband and I. So why is there not that education out there when it's common knowledge that potentially thalassemia carriers are CF carriers?
Yeah, well, we all carry gene mutations for about 5 conditions, and so why do, the question is about why do GPs not know that, why don't they provide information? Don't know the answer to that, but you're right, the message isn't out there. The message is slow, and if you're lucky you might get asked if you have a family history of cystic fibrosis, and as we know, 95% of babies with cystic fibrosis have no family history. So yeah, and you might find out about the thal. So that's really what we're about. I think that's part of raising awareness about cystic fibrosis. It's probably as much raising awareness in the community, because people know about Down syndrome, and so they might actually ask for a test if it's not offered. And if people are actually asking their doctor, what about this, then that's another approach rather than being passive. But it is a crowded space, so you turn up to your GP, it might be a shared care GP or your obstetrician, say I want to get pregnant, and they say fine, well, go off the pills, stop drinking alcohol, stop smoking, get healthy, eat more vegetables, have a whooping cough booster, have a flu vax this year, and let's check a few things. And so, now that sounds really quick, and I can do it quickly, but it's interesting that trying to slot in cystic fibrosis screening isn't there. Of course, one of our obstetricians who does a lot of screening, he's picked up 10 or 15 carriers, hasn't picked up one woman with syphilis, but that's part of the standard obstetric batch of tests. And of course, obstetricians were very quick to pick up HIV as a test, because they could catch HIV, and not unreasonably, but they could catch HIV, but they're not going to catch CF. And of course, by the time the baby's delivered, a bottle of champagne delivered to the obstetrician's office, he or she's out of the scene, and then you get the call from newborn screening, that terrible call. So we've got to raise awareness. I think that's where, I hope that's what you see, that where CF associations can come in and help. So in that vein, there's a group through CF Victoria who have last year and through till next year put together the carrier screening education program chaired by Ross Fraser, and there's lots of people involved, but that again you can see that sense of collaboration with partners, and particularly acknowledging funding from Rotary, the Baldwin Club, and Grantham's been involved, and very generous funding to enable us to do this. And the aim is to promote carrier screening in the community of Victoria and promote carrier testing of relatives for people with cystic fibrosis. And that's really hard conversations to have. People know they maybe should, don't know how to, and what we want to do is, and have done, is start to develop some tools that make that conversation a whole lot easier. And this is something we've been hoping for, and Well, I have, because everyone says, what do people with CF think about screening? And so CFV have come out with a statement that I quite like. I can see Nigel in the audience. CFWA, Nigel, is that statement? It came, it flowered, it hard to find on the website. Is it there? Is it?
Yeah, look, the work that CFB have done in this area is entirely compatible, and we're hoping that we can actually get some funding to roll it out as a national program in the future. But yes, it's consistent, and really when we look at the response of people with CF towards carrier screening, they are quite polarised, in so much as people, some of them say, well, I'm against it because I would never have been born and I like my life, on one hand, and to the other people who say, that would be great because I know that I would be born without CF and live a more normal life.
And I think that's, you know, we're always going to have, aren't we, a degree of that polarity. I guess what I've always hoped is that whatever, you know, your view might be, or one's view might be, it doesn't prevent someone else making a choice or having a different view. But anyway, look, I think this is a very, but thank you, Nigel. From CFV, CF supports individuals having an opportunity to make informed life and reproductive choices as a result of carrier screening, and supports efforts to make carrier screening accessible for anyone who's interested in learning about their CF status. And here we go. This includes raising awareness of CF, awareness of carrier screening services, and addressing other potential barriers to access and informed choice. So I think that's a really balanced statement. So what have we been doing? So there's a policy, there's some media work, there's a really nice website. So if you want to write anything down, perhaps jot that down to look up, and some of the information and tools are there. There's professional promotion, and we've also got another survey of GPs and obstetricians that's been completed by a student, getting out to genetic counsellors, and community promotion, and the survey that I want to share with you, and obviously our website and tools there. So this is some of the material, and this is a poster. It's up in my office at work, and this is some of the other information that's there. This is a newsletter that's gone out to the network of genetic counsellors, and some other media work. It's very, very smallly printed, but in fact in there it talks about life of kids with cystic fibrosis, and is really trying to present a few different perspectives, and isn't all about having a test and making hard decisions. It's about thinking about CF and what that might mean for you as a new parent, thinking about your options. So I like the wording in there. So we've done a survey of carrier screening and testing in Victoria, and with the idea that carrier screening for CF identifies couples at risk. We know that. The attitudes of members of the CF community to carrier screening are not well known, perhaps, rather than just not known at all. And there's also some question, I think, is the role of CF Victoria in raising awareness of screening. So we wanted to survey the members. And this is the poster that's going up in the medical session, which I don't know why you guys don't get to see the other posters. So I put it up at the back. So if you want to look for a few more details, you can. So we had a purpose-designed survey about carrier screening with an online survey tool using SurveyMonkey. Really good. You develop your tool, you put it up on SurveyMonkey, and then sent to members of CFV and a link on the Facebook site. The difficulty with that is hard to know who you've reached and what the true denominator is, and it's hard to know something about who's replied, and of course people who haven't replied might have just as interesting views or important views as people who haven't. So we just have to recognise that. But we got 214 responses, so we got quite a lot of responses, most of whom are female. It just seems to come out like that, like the population in the room, and quite a lot older than 35. Mostly parents, some grandparents, siblings in that group. Knowledge. So 71% knew their CF carrier status. But what's interesting is in the second, in the white there, is, I wonder if that's a laser. Is that a pointer, Robert? Is there a pointer there? Yeah. Which button? Oh, that one. So no, didn't know. So actually not a surprise there that most people didn't know they were carriers of cystic fibrosis. I think is really important point. And found out sort of too late to make any choices at the point. Now, one of the other things I asked, well, when should you do carrier screening if you're interested in doing it? And what was an open answer, you could choose lots of times. And I guess that's what this slide tells us, is that there's lots of times to do it. So when you're thinking about having a family, so ideally before pregnancy, although 50% of pregnancies are not planned. I don't necessarily mean they're total accidents, but they're not planned in the sense of getting ready and all the things we talked about that an obstetrician or GP might tell you to do. Should be done for all children at birth. Well, it's, people don't see a problem with screening children at birth. There are other groups who may be less interested in screening kids at birth. It's not quite so relevant for them. Although from newborn screening, quite a lot of kids are diagnosed, or infants, as carriers, and it doesn't seem to be harmful to them or their families. When someone else is diagnosed with CF in the family, and it depends on different situations before getting married. So there's a whole range of possibilities of time that you might do screening. Now, who's discussed it with family members? So, yep, 74%, but no for lots, and there's all sorts of different reasons that come out. Not everybody's close with their family, and that's probably part of the challenge. Or maybe there's members of you might be the youngest sibling and all the older siblings have had their kids and all moved on. You might still feel some obligation to your nieces and nephews if there are other kids. Discussed with who? So within the family, nieces and nephews. So there's a whole variety of different people who it's been discussed with. So I get a sense that there is a bit of discussion going on with families, but it would perhaps be nice to see more than 74%. How did you communicate it? Face to face. But through our genetic counsellors, we do offer a service whereby if you nominate family members that you don't wish to speak to directly, that we can send a letter anonymously. There's quite a sort of discussion about the ethics of that, and it seems to be quite a reasonable thing to do, that somebody in your family has recently been diagnosed and you may wish to avail yourself of counselling and testing. But I think it looks like most people who've said yes, that they've discussed it, have done that face to face. And what support did you get? And I think what's most interesting in that data set is how little support from GPs. And in some of the comments that came through, it's really a sense that people didn't have confidence, right back to your point, in their GPs providing them with accurate information. And I think that that's a real failing in our medical education and medical practice. So I think, few people in the CF community had carrier screening before the birth of an affected child is pretty clear. The group as a whole did accept that carrier screening, that the community carrier screening was a reasonable thing to do, with opportunities to offer screening at different life stages. There's a lack of confidence discussing with GPs, and I think CF Victoria has an important role providing information about CF and promotion of carrier screening in the wider community. So what are we going to do? Well, we're going to liaise with the medical colleges. I've already liaised with the College of Physicians, RACP. Got a letter back from the president, who happened to be, it's an Australasian college, he's from New Zealand, and he wanted to know what all the Maoris in New Zealand thought about carrier screening. A sort of curious way to knock this on the head. So I have to go and survey every person who of Maori origin to see if we could offer this. I actually approached the Thoracic Society through the Cystic Fibrosis Special Interest Group, and it went to the next level to someone high up in the organisation who's a thoracic physician involved in the Thoracic Society, but not actually involved in CF care, who basically said, why would you do this? CF's about getting a chunky cough when you get a cold. Okay, so that's pretty confronting. We haven't yet approached RACGP, and we have talked with College of Obstetricians and not been able to get them over the line to make a specific statement about cystic fibrosis. And part of their reticence, I think, is putting their practitioners on the other side of the line. So if they make a recommendation, then they've got to get out to the 1,000 obstetricians, and that's difficult. Interestingly, in North America in 1997, the National Institutes of Health made a statement pretty much like the HGSA. Everyone Caucasian planning a pregnancy or early pregnancy should be tested. And then the American College of Obstetricians and Gynecologists with their joint American College of Medical Geneticists got together in 2001, sort of out of the blue, took that NIH statement from a few years before and made a pronouncement. Everybody should have carrier screening and pregnancy. And it put a lot of obstetricians on the wrong side of the recommendation. A lot of concern about lawsuits for people who haven't offered it. And in fact, it's driven a lot of carrier screening in America, such that recently a report from the Massachusetts Newborn Screening Program that the live birth prevalence of babies with 508 was half. So it's interesting. Clearly in the obstetric space, they're the thought leaders. They lead the shared care GPs. So I think that's a group that we need to get into. But we've been, and Martin Delticchio worked closely with Bean, I actually think that it needs to be the community of people with CF if there's interest to go and help. Similarly, liaison with government is one of the plans that we have, but I don't think it should be just CFV. It would be nice if it's the whole group. And we're developing a video tool to augment those paper-based tools. So we've got quite a lot to do over the next 18 months or so. I just wanted to share some other data. So this is really the only two studies that I wanted to share some data with. And this was a study in Victoria at the Alfred Hospital 2011. Anna Lever, genetic counselling student, did that. And we wanted to survey what the thoughts were of people with adults with cystic fibrosis and what they did. So it sort of complements what we've got from CFV, where we don't necessarily really know who's answered the questionnaire. This is basically to adults with cystic fibrosis. And in one of the early questions was, are you supportive of carrier screening for everybody? And the answer is in the blue at the bottom is 90%, 90% yes. And that was regardless of how people perceived their own illness. So a lot of them, the question, how sick are you? Which is always an interesting question from which side of the table, patients or medical side, said, oh, moderately unwell. And I'm okay with that. But if someone else wants to make a choice, I'm also okay with that. And here's interesting, mostly because some of the answers are wrong. So couples, so in the second response, couples who have a child with CF usually have a family history that's just got lost in cutting and pasting in there. And in fact, the response there only 65% correct. So it's sort of interesting even amongst the people with cystic fibrosis. And remember, this is one of the common community fallacies. Have you got a family history? No, therefore you don't need testing. So this is from the CF group. And CF carrier screening can detect all people with CF. And of course it can't. So with 2,000 CFTR gene mutations, trying to pick out the severe ones, the ones associated with pancreatic insufficiency and bronchiectasis, ones we know what the phenotype or the clinical expression is. And most of the panels that are used pick up about 85 or 90% of those. So we're going to miss some and be test negative. But it's interesting that the group didn't necessarily know. This is what would you do if you were thinking about a pregnancy. So it was a hypothetical test. And although the numbers here, remember, most of the people are in support, so that's 136 people, and the orange is only 7 people. But most of the people said that most of the adults with CF said that they would use genetic counselling and carrier testing of partners if they were planning a pregnancy. That's interesting about conversations. So again, the blue is people in support. That's over 130 people. And most have had conversations about carrier testing with family members. It's interesting though about carrier screening for their wider circle of people, their friends, more distant relatives. Not so common to have had that conversation. And level of support for population-based screening at various life stages. So a little bit like what we learned about from in the CFV survey, quite popular in high school. That's where it's done for the Ashkenazi Jewish population, where they screen for about 6 illnesses, one of which includes CF, and it's part of the Year 10 biology syllabus, and then there's consent, and then they do the testing. It's not something that we've necessarily been so positive about for CF carrier screening, much more interested from the group of us working in this area about targeting people planning a pregnancy, so people who've already made life choices and coupled up and then make some decisions. But it's interesting that people with CF sort of really, get it done sometime, I guess, is the message that I get from that. Is it the right question? Because what everyone says to me, what do people with CF think about carrier screening? And it's a natural question and it's a really good question. But a lot of screening, though, I think, is about what do people planning a pregnancy think about carrier screening? Because most of them have not even heard of cystic fibrosis. And so this was a study that Leanne Ainu did over at Monash and at Dandenong, so that's in Melbourne, sort of out in the east, sort of, and far east of Melbourne. And she was in a standard obstetric clinic. And here's my worry about those clinics. You turn up because you make a choice to go in the public clinic. Perhaps that's an economic choice because it's very expensive to go privately. You go into a very busy service, and perhaps people here who've been through that, where a lot of it's led by the obstetricians but delivered by the midwives who are very experienced at getting through all the things that we said: stop smoking, stop drinking, have your rubella titers, have your syphilis test, have your HIV test, have your blood count, or you might have thalassemia, and all of that. And the space is crowded. I also worry that there is a test in Victoria, but none of these people have heard of it. I also worry that people in those clinics are making choices, and I think that broadly happens in medicine too. It's not just around this. I don't think you can afford that test, so I don't feel morally obliged to tell you it exists, because you come to this public clinic where you get this standard package. And we'll hide behind, we haven't got time. That's sort of true, but it's pretty quick, really, once you get going and know how to do it, to have that conversation. So, about half, it's really hard when you put in questions about race, because where are any of us from? We're all people, although I guess it makes more sense in European descent people than Southeast Asian people. CF is very rare, but it's better just to treat everyone the same, I think. And 80% of them, of the 158, thought that carrier screening, when they were told about it, should be offered. And at least half of them would have liked to have been offered it during their pregnancy. So I think as a sample of your average Jill out there in the community, that's an opinion about what they think they might like to be offered. Now, the whole game has changed a bit with these new drugs that activate CFTR. And you might think that poor old John Massey is out of the speaking tours off, CF's fixed, and carrier screening was an interesting idea, but what a loser. He backed the wrong one. And actually I think taking a really positive view about it, I think it's completely the other way round. So I guess everyone here is really familiar with the dramatic results of ivacaftor in people with the G551D and mutation and other gating mutations. And it's interesting, isn't it, that when we started screening, we say, well, let's screen because one of the paradigms is there's no cure and daily treatments are rigorous, and we know it's fairly easy to test the genes. But in fact, we've substantially changed that paradigm now, at least with ivacaftor in people with those gating mutations. But I think that, and then also when we've done our health economic analyses, which cost out the lifetime care on average around $300,000, which doesn't sound that much, but that only takes into account direct medical costs. And you balance that against the cost of screening, and that's data that we've got, and that once you start having a second and third kid, it falls in favour of screening. But if you add in the cost of these drugs, wacky-doo, it falls right in favour of screening. But you've all of a sudden got an ethical dilemma, haven't you? Because here's a treatment that makes a substantial difference. And here might be a pregnant woman who's got at least 1551D, and what do we do? So we wrote this paper, and it was mostly to educate genetic counsellors. Surprisingly, they weren't that knowledgeable about this field. So you've got to include this information when you're giving people genetic counselling. But what some of you may or may not know, when a baby's born with cystic fibrosis, pancreatic insufficient, quite a lot of those bubs on day one, so imagine a baby with 551D, day one, not pancreatic insufficient. And in fact, work done by Kevin Gaskin many years ago in Sydney at Camperdown showed that of the group becoming pancreatic insufficient, so that's 85% of people with CF, about 60% are born insufficient. Another 30% lose that pancreatic function during the first 6 months of life. So now, of course, you can't get hold of Kalydeco till you're 6 if you have 551D, but imagine you could get it on day one. And then go, wait on, meconium ileus, pancreatic insufficiency, absent VAS, that all happens in utero. So imagine having it during pregnancy. And we're starting to give pregnant women stuff, particularly vaccines. So in fact, if you don't screen, you won't know, and those opportunities will be lost. So I think screening really has a role, even in this era. And I think we also have to be accepting that there will be people who will who will say, well, sure, you've got this drug that dramatically changes things, but that perhaps is too much of a medicalised life for me to want to support a kid through, or me and my partner want to support a kid through. So we'll make choices, and it may not be choices that you make, but those choices that are legitimate in our pluralistic society. So I think it's actually really exciting, but I think it's even more reason for us to get on and do some screening. So back to what can we do. Now, as I was going over the talk, I thought that I had this a little bit round the wrong way, in that probably in the middle ought to be CF support organisations. But basically remember the disconnected elements of care and how we managed to get something going in Victoria, but nowhere else really is managed. And this is where I think CF organisations can pull these disconnected elements. Because CF physicians, we look after kids with CF. Geneticists look after kids with every other genetic disease, but not CF, but they hold the gateway to the tests. Obstetricians, they supervise the pregnancy, and they're there at the beginning, but not at the end so much. And obviously community awareness of CF is so important there. So I think CF organisations have a big role for the next step. So, what are some of the options? CF Australia policy. I think we're working towards that. Medical college support, not just from whinging doctors at Royal Children's Melbourne, but from the group of real interest to show they're not afraid of it. Of course, community awareness and government lobbying. These are some ideas. Chief Medical Officer, Health Minister, local members, NH and MRC. Now, I want to finish with my last story about a dear old lady who's 83. And Pamela has 2 nieces and a grandniece with cystic fibrosis, and you might notice the startling similarity of Pamela's name with my name and the similarity of that family history. So that's my mum. And no one's ever said no to my mum, and I sure haven't, and neither could Malcolm Turnbull. So she went down to a local member, who's Malcolm, and had a conversation about carrier screening, and she personalised it. Malcolm, what are you going to do about carrier screening for cystic fibrosis? It's really important, and I know about it. And so Malcolm couldn't say no. So we got a bit excited, and of course he wrote to Peter Dutton, who was the head of, he was the health minister at the time. Now, of course, Peter hadn't met my mother, and Peter's got a team of bureaucrats behind him, so it was fairly easy for Peter to say not much in response. But I thought it was really nice that we got some sort of response, and that was forwarded to Pamela. And also there was acknowledgement of the role of CF Australia in raising awareness and in a sense an invitation to say, come and talk with us about it because you're recognised, this is CFA is recognised as the interest group. So we have lots of data about screening, but data doesn't really convince anyone. It's that personal approach. It's anecdotes, it's lots of anecdotes. You put lots of anecdotes together, you get lobbying. And I really don't believe that CF carrier screening devalues the life of people with CF. I think what it does though is offer choice to people. And I think that carrier screening also widens the network of people who know about screening and who are supporters of cystic fibrosis. So thank you. That's the end of my talk and happy to take some questions.